All right, welcome back, Health Impact audience. We've got a jam-packed session in the next 45 minutes or so, talking about population health, but population health has taken on a brand new meaning in the last few months. So we used to talk about a population health institution-focused. So we have our organization and we have our patient census, and that is pretty much our population. Now, when the health system talks to the community health people, population means different things. But now, during the time of COVID and the pandemic, everybody's problems are everybody else's problems as well. So the community is much bigger. Population health means quite a few different things. And so we've got a great panel led by Polly Israni from Google. So what we've seen over the last few years, lots and lots of hospitals and health systems reach out to Google in very specific ways, trying to get them to take the magic that they've given on the consumer side and bring it into healthcare, especially at the patients and providers. The user experience and the capabilities that they have are just extraordinary. And getting any time from these guys to spend with us to talk about what they're doing in healthcare, helping especially the customers that they're helping is terrific. So Polly leads the cloud marketing team for the providers and health plans side at Google. So she'll be taking over from me here, introducing the panelists, and then asking the questions. So with that, Polly, please take over.
Thank you, Shahid, for the awesome introduction, and welcome everyone that's on the call today. So I'm Polly Israni. As Shahid mentioned, I lead our marketing for healthcare organizations in Google Cloud. And like many of you, we're focused on supporting healthcare communities through these unprecedented times. We've done a complete pivot to really focus on COVID in a lot of our activities in healthcare. And most of it is focused on data and cloud technology. So this, at Google, for us, what that means is it includes analytics and health high-performance computing to help hospitals understand and organize information, and also helping those that are on the front line, so some of the caregivers with telehealth and other services to keep everyone safe and outside of the hospital oftentimes. COVID-19 has created significant stress on healthcare providers, as we all know, and in this session, we're going to focus on one particularly keen issue right now that's important to me and that's been talked about a lot lately on health disparities and a look at community health. So we'll talk about tech to address and assess the risk. We'll also talk about how data can be used to increase the awareness of existing vulnerabilities and how they will be heightened during this time and how they've already been heightened. And then an approach to targeting during this time of what hospitals are now knowing as a time of resiliency and really pivoting and being able to adapt to these times that are changing. So I'm privileged to also have three amazing speakers who are influencing great change right now in the industry during these times. I want to start with Sabina Zak, who's the VP of Population Health at Northwell. She drives the development, integration, and administration of Northwell Health's community health and health services resources. She oversees all the community health-related policies, services, programs, financial and strategic planning activities, and she's got a wealth of experience in healthcare, including contract negotiations with physicians, union contracts, managed care companies, and external vendors. She joined Northwell after servicing as a chief operating officer and a chief affiliation officer at previous organizations, and happy to have her here. I also want to introduce Karen Thompson, who's an AVP of Regional Community Engagement at HCA. She leads the Regional Community Engagement Strategy there and is a very sought-after strategist who leads planning sessions within HCA for supply chain, centralized pharmacy, of relevance here, the corporate data science team, and a number of other groups. She's involved in several community initiatives, including boards of HCA Corporate Foundation and Nashville Public Television. And she's got community leadership that's produced more than 1 million in tech solutions for Nashville nonprofits. I also want to share that she's selected as one of 9 leaders representing Nashville in HBS's 2018 Young American Leaders Program. And she's particularly committed to women's mental health, and so looking forward to hearing more about that today. And then lastly, we also have Nabil Shahadi, who's an SVP of Population Health, Metro Health. He's also got an MD, so clinical background, and can represent some of the clinical aspects that he's seeing in the community right now. He's an SVP of Population Health since August of 2016, and he's been playing a critical role at Metro Health in transforming the clinical and operational approach to population health. Prior positions, he's been the president and CEO of HealthSpan Physicians Ohio, president and executive medical director at Ohio, and Ohio Permanente Medical Group. So with that, I want to just kick off our conversation with everyone. It's obviously a very illustrious panel, and it's going to be an interesting conversation. So looking forward to diving in. Let's start with technologies that are being used to connect patients with critical social and community support services. For example, the thing I think of here is social determinants of health for digital technology, and really targeting and matching individuals with necessary services. So can you talk a bit about what you've seen at your health system? Sabina, I'd love to start with you here at Northwell.
Sure. I'm glad to be here. Thank you so much, Polly, for the introduction. So let's talk about social determinants of health a little bit. When we talk about that, and when we often talk about social determinants of health, yet the breakthrough work that's needed from both the policy and payment reform is still very much lagging behind. Addressing the social determinants of health and preventing people from getting sick can be a more effective strategy than simply treating them afterwards. Social determinants of health are fortunately getting much more traction in healthcare and in policy, and largely because of the pandemic that we are dealing with now. What we've seen during COVID and, really nationwide is that certain populations have been impacted fairly worse than others. Blacks, Native American Indian, and Latino communities face the highest rates of severe illness. And you can start seeing that even with the data within Northwell, that the socioeconomic status also played a role in these risk factors. COVID has made health disparities worse, but luckily technology platforms could be the tools that we can use to fix them. But reality, if we want to make that collective difference, we must invest in platforms that are both meaningful and actionable. So, I always say that technology is a platform, it's a tool, and it's as good as the users who end up using it, both from the healthcare system's perspective, but also from the patient's perspective. Therefore, it must be, meeting the needs both of the healthcare system and of the communities and the patients that we serve. We all know that health and wellness actually begins in the home and in the communities in which we live. Zip code does matter. And it really does not start within the four walls of our healthcare systems, right? It doesn't start with a doctor's office or in the hospital. What we did in Northwell, when we developed our social determinants of health program, we really strategically developed it with end-to-end solutions in mind, in a way that we can standardize and replicate it throughout the system by effectively integrating the screening into the EMRs, understanding the non-medical diagnoses in real time, visits, and leveraging the referral platforms to connect health systems, health providers, and health plans to community resource in areas that patients live to address their unique needs. We have connected patients to a wide variety of services, including those of behavioral health specialists in the community, working with nutritionists as part of our Food is Health program, and obviously with community-based organizations who can then further take action and serve the needs of our patients. Our plan was really not to only, collectively focus on referral platforms, and there are many out there, but it was really about making sure that we look at different technology platforms like AI chatbot technology to look at those end-to-end solutions where we're leveraging more of the digital platform to create, again, creative and innovative ways to address some of these disparities. All this work is obviously being researched very in detail, but it is also helping us in, the policy work on the state and government level and how collaboration between healthcare systems, providers, and community-based organizations can improve individual health and well-being. I do have to say that the referral platform that we've engaged in and worked very closely with community-based organizations has had really positive feedback, even from the healthcare perspective side. The feedback we've gotten from social workers is that they find that it's a go-to platform to ensure that services can be coordinated fairly well. And the feedback that we ultimately get, whether those services were rendered or not, is also very powerful because it helps us make that business case at the end of the day, not only about the quality of care and health impact, but also about, whether those relationships are working or not, and helping in the payment and policy reform that is ultimately very much needed.
Awesome, thank you. I actually have follow-up questions to that, but before we jump in there, I'd love to hear Karen and Nabil's perspectives on this as well.
And, we've made a number of investments as well that we're leveraging for this. And so what I want to actually address and go back to is, while technology is certainly going to be and has been a help, one of the things I think people don't always fully appreciate is, yes, those populations are vulnerable, and so just having technology alone is not going to solve the social determinants of health. They're vulnerable because we have an infrastructure that's not been invested in. They're vulnerable because they've been disenfranchised for a long time, right? They've been vulnerable because we moved away from intervention and prevention work. And so one of the things we're taking on at HCA Healthcare is a Healthier Tomorrow Fund, where we're actually investing in some of those underlying conditions that create the vulnerability to begin with. Because while we do have technology that will help us with triggers and look at those who have chronic conditions, and we've got something called, one patient, one list. And so when a patient is entering in our system, in particular for conditions, let's say with maternity, with a high rate of infant and mortality rates, especially for Black and Brown women, 3 times as high, with the one patient, one list, that gives us the ability to just track every encounter that patient has with our system, and it shares that information not only with those who are in the system, because just like maternity issues, and you could take any other chronic condition, you have a number of different physicians that you're working with and clinicians inside and outside of our system. That tool allows us to share that information with all those involved in giving the care, which is incredibly important when you're talking about the care outside, so they have that one view of the patient, so it can be more holistic in how we treat them. But I say that to say, what we step back to say is, you've got to find ways to start to invest in food insecurity. By the time a patient gets to us, those underlying conditions, if we're not looking at that as a whole person and partnering with nonprofits and partnering with others that are in the healthcare ecosystem, the technology is just going to be a nice, pretty dress on top of something that's just so funky, right? It's messy, it's complicated. And right now, I think of the silver lining with COVID-19 is it's really helped, I think, as Sabina said, is it's helped us all draw light to what problems were there that now are just like, you cannot walk away from it any longer.
Thank you for sharing that, Karen. Nabil, I wanted to ask you specifically about some of the screening that you all are doing for loneliness and stress as part of the social determinants of health. I'd love to hear more about that work and how you're seeing it impact these populations, how you're using tech for it to evaluate it.
Sure. So we are at Metro Health. We are the largest public safety net hospital in Northeast Ohio. And we've been in Northeast Ohio, basically this is Cleveland, Ohio, more than 183 years. And we are home, and our largest employer in the city is healthcare. And we're home to the largest healthcare organization. And despite this, you can find close to Metro Health, 2 neighborhoods separated by basically 2 miles apart. There's 23 years difference in life expectancy. Moreover, despite being having the greatest healthcare organization in our community, our health outcomes are way, way low in the community compared to the rest of Ohio. We are ranked at the really at the bottom in the state. Having said that, Metro Health all along knew those things and understood that health and wellness is truly, truly more than just healthcare. And we have been dealing with social determinants of health since our very start of our existence, from the polio, TB, et cetera, et cetera. And when I first came in here to Metro Health about 4 years ago, we looked at what are actually the programs that have been put in place here at Metro to address the social determinant of health. And I found numerous programs, more than 150 specific programs, all have separate funding, separate management structure, et cetera. what we marched upon is put all those programs in a very organized way, and we created an institute called the Institute for Hope. It stands for Health, Opportunity, Partnership, and Empowerment. And we started that journey about a year ago. And part of that journey is truly to screen all patients that either come to us or we outreach to them that are in our neighborhood. We started that very purposeful screening about 6 months ago, and we've screened about 10% of our patient population already. And screening them for the sake of screening, as you all know, is not good enough. We take that discrete data, we'll try to find other known data that we can capture on this patient population and combine those data so we can create significant targeted action for those patients. And one of those things that we have found, and we found more recently, especially after the COVID, is the social isolation issue. And the question is, how do we deal with this? We do connect, and more recently with the COVID, and we have a process where we have anybody who suspect of having COVID to call us and get a telehealth visits instantaneously with a provider. We follow up on those patients, and once we follow up with them after they're being asked to quarantine at home, our Institute for Hope makes specific calls, screen them specifically for social determinants of health, and what we found out, social isolation is the #1 issue. And we have our community health worker, and sometimes we connect them to behavioral health specifically to give them some emotional boost, if you might say. That's one thing we've done, and we've done very regularly. And I'll talk a little bit later about what the volume and the extent of that work. More interestingly, we also instituted something called a Call for Hope. And actually, this is a volunteer-based a group that we put together, and basically for the same purpose. We just identify through the screening who is in true need of those little support, and we make those calls for them, and we make sure that they are well supported. So those are kind of two programs that we have addressed, but there are many others that we've done.
So Nabil, you started to speak to this a bit, but my next question was going to be, in continuing care for these patients, what technologies are you exploring to enable the remote treatment and monitoring of chronic conditions in vulnerable populations? Anything you want to add to that, or I'd love to get Davina.
Yes, absolutely. I'm going to take you a little bit back through our COVID crisis. When we were just faced in the COVID crisis the second week of March, and it happened that the same week I get the responsibility to take over our call centers as well. And I found out that patients are calling and they're being mixed up with the general calls that you regularly have through your contact and call centers. Needing appointment, concerns about healthcare, but significant numbers, and there were a lot of delays. So we created a dedicated phone line just for the COVID suspicious patients. And we clinically triage by RNs every single one of those calls. So this is not a chatbot of anything anyway. It's actual human being talking to the patient and triaging them. And so far we've done about 25,000 of those triage, and about half, actually to be more exact, 13,000 or so, have ended to within 20 minutes, a virtual visit with a physicians. We have a small pool of physicians. This is 24/7, by the way. Very quickly, we put a protocol for a small pool of physicians that are very well educated around the protocols of COVID and how to diagnose and what to do with it. So very quickly, we realized early on we are asking people to self-quarantine, and without even testing originally. Now we test everybody that we're highly suspicious. And about 2/3 of those 13,000 we actually asked to self-quarantine. And this is why after we did this, I started looking and said, okay, we self-quarantine those people. Well, what's happening to them? What are we going to do about those people? So this is where it came very apparent, well, I have my population health people. Why don't we start making calls? I have my Institute for Hope, we start making calls. This one we start screening for social determinant of health, in addition to check on their clinical improvement and we kept on doing it for 7 days post the initial call. And part of doing this on a regular basis, this is where we identify there's social isolation. There are issues with people. We're asking them to quarantine, but they had no food access. So we started actually, my executive team, many of them, and we took our school health bus because we have a van, actually it's a van that we have for school health. And we started doing grocery shopping and actually dropping it to the people's doorsteps if we identified those issues. And then while we're doing this and connecting patient to behavioral health, to community health worker, to really getting them engaged and getting them what they need, some of those patients actually start crashing, clinically crashing. And we needed to send them, call 911, or we send them an ambulance. And this is where it really came in, the idea, okay, what else can we do? We're making those calls on a regular basis. What if some of those patients actually will benefit also from a physician follow-up call? So we start physician follow-up call. Then the physician starts saying, only if I can check on their pulse ox, what's their oxygenation level? Because this is one of the initial things that really happens with patients when they start deteriorating with COVID. So this is where we said, okay, let's evaluate very quickly. Within 2 weeks, we evaluated vendors and we selected a remote monitoring technology that we wanted to deploy to those patients who are either multi-comorbid disease or really clinically starting deteriorating from our initial follow-up. And this is how our hospital at home program really was born. And actually now we take patients directly from the ED, not just from the hotline. Our only protocol is a suspicious, or actually today it is diagnosed COVID and clinically unstable, not needing yet ICU. And we put them in this hospital at home. We treat them as if they are a ward in our hospital. There is continuous 24/7 monitoring. There is on-demand and at least twice a day nurse visits, check-ins, at least once a day, physician check-in. There are all kind of parameters and notifications if vital signs are not within the range that we put them together. And we put this together all in 2 weeks, and we keep on tweaking it. We had to figure out, how do you sanitize once the patient is discharged from this program? What do you do? What's the logistics of sanitizing those equipment, etc., so they can be safely repurposed after a few days? So we put a lot of effort into this, and it's going very well. We have admitted more than 50 patients so far. Today, I just looked at the census. We have daily census. We do daily huddles in the morning, in the evening, just like a ward in our hospital. And today, I have 15 patients actively in the hospital. I hope that answered your question.
It's fascinating. I was going to ask you about how you're bringing tech to them, but there's so many aspects of this. It's bringing.
We cannot talk. One thing about that. Truly, we made sure that the devices, because of our patient population, we made sure that all devices have LTE-enabled devices. And we pay for that ourselves. because we know that our patient population might not have access to Wi-Fi and internet. And we can talk a lot more about Wi-Fi and internet and what we're doing in the community to enable access to healthcare.
Awesome, thank you, Nabil. Let me also pivot that question to Karen and Sabina. I'm curious to hear how you all are also using technologies in the way to continue care and enable remote treatment.
Sure. I guess so. One of the things that I think we have to really focus on is how do we make it in a way that is culturally sensitive. We have to stay away from the concept of one size fits all because it doesn't. And so I think one of the ways that we had actually looked at making sure that as we leverage technology, it's really focusing on the fact that every patient is an individual with different backgrounds and different colors and different, biases and different thinking processes. And one of the things that we also really focused on is that in every outreach that we did, we made sure to focus on health literacy. And really health literacy is probably one of the most significant social determinants of health needs that is most times being undermined because, we do a lot in this space, but we don't do enough, and we don't do it in a way that really is more meaningful and actionable. I think most people know that health literacy is not just about the delivery of health information. It's, the capacity of individuals to obtain the information, process it, understand basic health information, and have the necessary decision-making factors, right, to take action. When we look at statistics, about 9 out of 10 people are really reporting low literacy levels, which is quite significant. And so what we thought about is when we looked at health literacy and really kind of engaging part of our, not only the screening process for social determinants of health, but also how do we communicate the results or the information that patients need to, absorb and internalize in order to follow through. What we've done is we really leveraged a lot of the AI chatbot technology on the front end, both on the screening side, where we're able to reach out to patients at any given time through text messages or through email, and are able to collectively deliver information to them in their preferred language, on their literacy levels, and in ways that we're able to collect this information and strategize, in terms of the priorities of patients' needs, and also depending on their responses, highlighting who do we need to prioritize the outreach to first, right? Because you can make calls, and not everybody's available through a phone call. But we found that more people were engaging through the text messaging or through the chatbot technology and able to provide us with answers. The other thing to consider is when you're looking at identifying social determinants of health, the screening process is super important. Most times, patients do not want to disclose information about social determinants of health because of judgment, biases, embarrassment. And when it is done through a third party or person to person, even over the phone, patients don't typically tell us, in truth, what they're experiencing. And so in the chatbot technology platform that we've built, not only are we explaining things to patients in terms of why we're going to be asking those questions, we're doing it in a way that is done in a 5th grade literacy level. And it's also done in patients' preferred languages. So we're able to communicate with patients much more effectively. The other thing, during COVID, we used the same type of technology not only to deliver test results on, their COVID-19, lab results, but we also used that opportunity to try to navigate patients to their needs. So if patients did have COVID-19 and did have to socially isolate, the next questions we've asked was around food, right? Are you food insecure? And most patients were, to some degree, had issues with access to food, but there's a difference between somebody who's able to purchase the food and go to Stop and Shop or purchase online through Amazon or Fresh Direct and other modalities versus somebody who heavily depends on SNAP benefits and depended on community-based organizations. And so we used that data, and what we did is work with community-based organizations to actually deliver the food to patients' homes and making sure that the food insecurity portion of that was addressed. So there's a lot of viability to looking at AI chatbot technology in terms of making it more patient-centric and making sure that patients can relate to the information that we provide, whether it's social isolation, whether it's food insecurity, whether it's homelessness, whether it is how to get health insurance or any benefits that they may be eligible for. It's got to be done in a way that patients can understand and not just a check mark on the healthcare system side to say, oh yeah, I did what I'm supposed to. We have to flip the lens and look at it in terms of what is the scorecard of the patients that we're serving, the communities that we're serving. Does this make an impact? Do they even understand? And what matters most?
What a wonderful way to close us out. And I just want to thank everyone for joining today and sharing your expertise. Thank you so much.